Welcome to the recorded version of the Grantmakers and Aging webinar, Improving Rural Health Outcomes, from September 19th, 2016. This Conversations with GIA event features John Feather from Grantmakers and Aging, Josh Hofmeyer from Avera eCARE, and Heidi A. Schultz from the Helmsley Charitable Trust. This event was made possible by a partnership with the John A. Hartford Foundation, the AARP Foundation, the Helmsley Charitable Trust, and Grantmakers in Health also sponsored the webinar.
Low average incomes, geographic isolation, and severe shortage of qualified healthcare providers create challenges in delivering quality healthcare in rural America. Today's webinar will explore the role of philanthropy in improving the health of older persons in our rural communities and how local and regional funders can be part of the healthcare solution. We'll also learn about an innovative telemedicine program supporting local staff in 7 rural Midwestern states. With us today, we have 2 experts in the field to help us through these issues. Josh Hofmeyer is Senior Care Officer at Avera eCARE, and Heidi Schultz is the Program Officer for Rural Healthcare at the Helmsley Charitable Trust. We want to welcome all of you. As we turn to our first slide, I want to take just a moment to tell you a little bit about a new program here at Grantmakers in Aging, very closely related to this, and also an upcoming effort that we have on it. Through support of the Margaret A. Cargill Foundation, Grantmakers in Aging has developed a new network for rural aging issues called a Sustainable Network for Rural Aging. We are launching this network at our annual meeting in Portland, Oregon on October the 26th to 28th. Those of you who are funders and can come to this meeting, we hope you will join us. We have 2 important sessions at that meeting that we want to alert you to. One is an intensive session, about 3.5-hour session on aging in rural America, creating a sustainable network to improve the experience. And then also on that Friday, we will be co-sponsoring a conference with Grantmakers in Health on the aging of rural America policies, programs, and solutions. We would be delighted to have all of you involved in this. If you'd like more information about the Network on Rural Aging, which is open not only to funders but other organizations interested in this, please contact Grantmakers in Aging. With that, Heidi, I'd like to turn to you as we move to the next slide and ask why the Helmsley Charitable Trust is supporting this issue of rural aging and the healthcare program serving rural communities in the Midwestern States.
Thank you, John. So I wanted to start, go ahead and forward this slide. So the Rural Healthcare Program of the Helmsley Charitable Trust operates in 7 upper Midwest states, and what you're seeing now is a map of the frontier counties of the United States. Frontier is less than 7, so persons per square mile. And as you can see in the states where the Helmsley Trust has the Rural Healthcare Program, which are North Dakota, South Dakota, Nebraska, Minnesota, Iowa, Montana, and Wyoming. There are a lot of frontier counties. Not in Iowa, there's only a handful in Minnesota, but the other 5 states where we concentrate our work have a lot of frontier counties. So while the program's name is Rural Healthcare, we really focus on kind of isolated rural and frontier regions. So I just wanted to start with this map to show you where we're working and why we're here. A lot of people ask why we're here, and it's a long story, but basically when the trust started, there was research done, and there was this area of the country that had a lot of healthcare issues, a lot of challenges, and not a lot of healthcare philanthropic dollars were going there, and that is how the 7 states were chosen. And as the researchers found the majority of the very small amount of funds coming into this region, most of it was actually going to the Mayo Clinic in Minnesota, so the rest of the states were receiving very, very little. Next slide. So besides being very rural and even frontier, we have a lot of counties and areas that are considered health professional shortage areas. HRSA has maps and designations for primary care, dental, mental health. We have a lot of health professional shortage areas in these 7 areas where we serve. And quite honestly, where you see areas that are non-HEPSA areas, it's usually because there aren't people there. So if you look at Montana, where the white areas are, those are mountains. In Wyoming, where the white areas are, there is just not many people living there. And the same with the other states. So it's pretty intense as far as the need for healthcare professionals in our 7 states. Next slide. And you really can't talk rural without talking about older Americans. Now, while older individuals aren't a separate piece of our strategy, because we work in rural and rural isolated and frontier areas, of course we are looking at a predominantly older demographic. So this map shows you counties with a high percentage of individuals that are 65 years or older. And I believe we have a county in North Dakota that has the most individuals that are over the age of 85. So we have small communities, we have farms, we have a lot of older folks trying to live independently, on the farmstead or coming into town for medical care and long-term care as well. So that's kind of why we're here. And this will kind of, I think, set the stage for why we chose to, one of our strategies is healthcare delivery via technology. Next slide, please. So to meet these needs, to get access to care out in these rural and frontier areas, we looked to telemedicine. And we serendipitously came upon a healthcare system that was already doing some wonderful telemedicine in South Dakota, based in South Dakota, and to some of their facilities in neighboring states. So we partnered, the Trust did, with Avera Health, and asked them if they would consider increasing their services from their hub in Sioux Falls, South Dakota, to match our footprint. And they were willing to match our 7-state footprint and expand their footprint. So we helped them build up their infrastructure within their hub to provide services beyond their system and beyond their what was their geographic footprint back in 2009. We mainly funded programs considering e-emergency, e-pharmacy, and e-ICU. And without going into details of those, it gives rural individuals access to, through e-emergency, to a board-certified emergency physician. And a lot of our towns are dwindling as far as what they have for pharmacy services, and the hospitals, well, most hospitals don't have their own pharmacist. And then we also helped fund eICU to provide intensive services and monitoring to rural hospitals. And you can go onto Avera's, Avera eCARE's website to learn more about those specific services. We're not going to talk about them specifically. Next slide. This will give you an idea. This is a snapshot of our 7 states. If you're not familiar with the Midwest, upper left-hand corner is the big state is Montana. Go to your right and there's North Dakota. Go down 1 state and that's South Dakota. And in the kind of lower right-hand corner is where Sioux Falls is located. So you can kind of see how the programs have expanded from South Dakota out into our 7-state area. So the legend shows you the red's emergency, the yellow's e-pharmacy, blue are eICU sites, and then the green are sites with multiple of 2 or more of those services. So one of the nice things that we've been able to do is not only build up the infrastructure for Avera to do this, but now we are funding critical access hospitals to be able to implement these services. Go ahead and advance the slide, please. The other thing that we've been able to do is, on top of providing those services, we helped fund what Avera calls the eHelm. We helped facilitate a grant to bring all three of those services, and now more, under one roof. So the providers and the nurses and the pharmacists can consult one another from the different service lines. So now they're all in one facility under one roof, and it's also, it's a beautiful facility, and it better enables us to tour people and show them what this is all about. So we did help with a grant to the actual building and technology, and then we also helped with a grant to kind of look at the feasibility and how they might be able to scale up these services throughout the nation. Next slide, please. So what Avera was able to do, because the project that we supported became self-sufficient, that was kind of one of our keys, was it needed to be sustainable. Also, we provide kind of business plans for each hospital going in to use one of these services to explain how it will be either cost neutral or that they'll save money and or increase revenue. We needed Avera to become self-sustaining with eCARE, and they went way beyond that, and now they have an innovation center. And as they provided more services, both their clinicians, rural hospitals, other clinicians throughout the Avera system are saying, this could be, you know, why can't we do this service through telemedicine? And so now they have a nice process to get ideas, kind of research them, do the feasibility, come out with prototypes, and then pilot programs, and then as they say, manage the flip, so they can get programs ready to go to market. And one of these programs or products that they were able to do this through the innovation cycle and kind of take what we're doing with them and take it well beyond that is a program called eLong-term care. And I'm going to go ahead and move it over to Josh to explain that.
Well, thanks, Heidi. I want to, before we let Josh give us some more detail about these very interesting programs, I want to remind the audience that we will have a time for questions and answers at the end of the session. You can go ahead and type in your questions at any point. You just open up the question box that you will see at the right hand of your screen, and that long box there. Just open that box and go ahead and start typing your questions at any point. So Josh, let's hear more about this program. Heidi gave us a wonderful background about why this is important and the issues involved in that. But could you walk us through the program more completely?
Certainly. Thanks, John and Heidi both. And so I am Josh Hofmeyer. I am the Senior Care Officer out at Avera eCARE in Sioux Falls. And so one of my responsibilities is overseeing eLong-term care, which we will be talking with you about today. So Avera eCARE, as you can see on the slide here, we really refer to ourselves as a virtual health partner. We have today 6 major service lines. Heidi touched base on e-emergency, e-pharmacy, and e-ICU. We also have e-long-term care, e-correctional health, and then e-school nurse is another one that make up our 6 main ones right now today. We offer 24/7 staffing solutions. Our goals really are to improve quality and patient outcomes, reduce delivery costs, and most importantly, support all of the local teams that we serve in the over 270 locations that we are at. Next slide, please. Avera eCare's 3 main goals really are outlined on this slide: improve patient care, support the rural workforce, and support financial stability. And when Avera started back in 1993 to provide telehealth services, it had these same goals, but they were supporting just the Avera hospitals that were out there. And Avera has over 20 hospitals in the states that they serve. And they quickly realized that this could go beyond, much beyond, just supporting the hospitals that were associated with Avera into supporting other customers through business-to-business relationships. And so many of our service lines are to that point. Now specifically to talk about e-long-term care. Next slide, please. E-long-term care really got its start back in 2012 with a HRSA grant. HRSA awarded eCARE $150,000 a year for 3 years to bring telehealth into long-term care facilities to try and see if there could be certain aspects of the care that could be done via telehealth to keep residents of the long-term care facilities at the facility versus always transferring them to an emergency department, a clinic, or to the hospital. And we'll get into some information here in a little bit that shows why that's so important. But back when this first started, $150,000 a year was not a lot of money to start a program such as this. It was enough to get a few things done on the technology side, find a few facilities that things could be trialed, but it wasn't enough to necessarily staff this program or to make it a wide scale. And so some things that happened during that time frame, some lessons learned, were we built it into the e-emergency department out here at eCARE. And e-emergency is a great department, extremely intelligent people that run that service line, but not trained to deal with the elderly that are in long-term care facilities and treat them in place. And so we quickly learned that in order to make this more sustainable and long-lasting, we would need to have a geriatric team that would be able to provide the support versus building it into a service line that already existed. We also learned that in the HRSA days, we were only providing urgent care access. So there's already a problem or an emergency that is happening at the facility, and they would call out here. And with providing care in long-term care, you really need to be as proactive as you could. So we knew we needed some sort of shift towards proactive care. And the last thing we learned is we were going to need technology that could be brought to the resident versus the resident brought to the technology. And we were going to need to have some type of wireless equipment that we could utilize. So with all of those lessons learned, we knew we'd need more funding to really get this off the ground. And so eCARE applied for a CMMI award, Center for Medicare and Medicaid Innovation. And in 2014, September 2014, for the round 2 awards for CMMI, eCARE was awarded just under $9 million to really grow this program and try to show what kind of impact it could have if it was brought to a wider scale across the residents that it serves. So today we do have, actually we're growing a little bit beyond this, but we have a little over 2,500 residents right now today that are on the program. We operate currently in 4 states, Iowa, Minnesota, Nebraska, and South Dakota are the main states we operate in today. Next slide, please. CMS has really outlined 3 goals. When they first adopted them, they were called the triple aim, and they're moving away from using the triple aim terminology now, but the same goals still apply really, to have better health care, better health outcomes, and to lower cost. And so we set forth to adopt those exact same goals with the program that we are providing. Next slide, please. I always think it's important for people to understand, why would telehealth be valuable in the long-term care industry? And so I have a couple of slides here where I'm going to talk about the challenges that currently face long-term care. In the elderly population, we know that geriatric-led care, care by a geriatrician, is associated with fewer ER visits each year and also a lower cost of care of 10% or more for the elderly. The problem is, in the United States, there's only 1 geriatrician for every 2,200 elderly people. And so in the state of South Dakota here, for example, we have only a handful of geriatricians for the entire state. And when you look at the geographic area and the number of people who are 65 and older in the state, there is no way that only a handful of geriatricians can really provide care to all of those people. So you really have to start looking for a way to streamline the care that can be provided by geriatricians. Next slide, please. So in most cases, long-term care residents will find another primary care physician that can follow them, a family practice physician at the local clinic, or sometimes they have to go to a clinic that's 50, 100 or more miles away just to get routine care by a physician. And those physicians are taxed with numerous things already, such as their busy clinic work that they're doing. A lot of the small communities are also taking call for the emergency room. They're dealing with all the long-term care residents and the calls and the faxes that come in for orders for them. Plus, most of them would like to have some type of family life, and so they get burnt out pretty quickly. And this map here shows all the areas that there are already physician shortages, and by 2020, they're predicting that the United States is going to be short an additional 45,000 primary care physicians and over 46,000 surgeons and medical specialists. So this just makes things even more complex when it comes to trying to find appropriate care for people in long-term care facilities. Next slide, please. On the financial side of things, there are 5 million hospitalizations on average each year that come from long-term care facilities, and CMS has studied those and said 46% of those on a conservative level are avoidable and did not need to happen. So each time a long-term care resident is hospitalized, it costs on average CMS over $11,000. So this equates to $15 billion a year that is being spent. And almost half of that, nearly half of that, is essentially something that could be avoided if the proper care was in place at the long-term care facility versus having to transfer the person unnecessarily to an emergency room or other setting. Next slide, please. Long-term care facilities themselves also face a lot of financial risk, and this slide is really set out there to depict the fiscal cliff that a lot of long-term care organizations find themselves on. They are not known for high margins in long-term care. CMS does a pretty good job of reimbursing them on people who are on post-acute stays for therapy, but in a lot of states, there's a lot of Medicaid shortfalls, and the majority of people in long-term care facilities are on Medicaid, and so they really count on those dollars for Medicare and from CMS to help offset that. But Medicare is also going broke and quickly running out of money. And so a couple years ago, they went into sequestration and took 2% away from all of the things that they were funding. On top of that now, value-based purchasing is coming out in the healthcare industry. And so hospitals are already dealing with this in a lot of areas and having value assigned to the care that they are providing, and they're looking at quality, and then they're withholding dollars depending on what the outcomes are. And that same program is now going to start taking place in long-term care facilities, and they're specifically looking at unnecessary transfers to the ED and rehospitalization rates. So they're going to start taking money away from long-term care facilities, 2% of their funding, and those long-term care facilities can get that money back if they have good scores compared to their peers with rehospitalization rates and ED transfers. So they want both those rates, of course, to be low, and want to see that the long-term care facilities are providing higher quality care and treating people in place versus always transferring them. So this slide really, again, just depicts the cliff that they are on fiscally and all the upcoming opportunities with recommendations from MedPAC and the value-based purchasing and quality that they are facing for a loss in revenue. Next slide, please. On top of all the fiscal complications that were on the last slide, long-term care is also faced with the fact that the past is changing. So in the past, a hospital would discharge patients to numerous long-term care facilities. They would just look for a place that they could get the patient out of the hospital, send them, and let them take care of that patient. And the hospital, it's not that they didn't care, but they weren't penalized if that patient came back. So if a facility was sending people back all of the time, it didn't necessarily hurt the hospital at that point, other than there was a lot of in and out taking place. But in today's value-based purchasing world, that penalizes the hospital. And so they are looking for long-term care facilities, hospitals are, as well as ACOs, that they can partner with where they have low ED visits, they have low rehospitalization rates, they have QAPI stands for Quality Assurance Performance Improvement. And so they're looking for facilities that have a good QAPI program, that are using technology, that have a good CMS star rating, and that have high levels of customer satisfaction, so that these residents are being taken care of in the facility that they are being sent to from the hospital, so the hospital and the ACOs can better manage their resources. So the days of sending them to multiple long-term care facilities really are gone, and they're just looking for those 2 or 3 places that they can really partner with for going forward. So with all of those challenges in mind, from the physician shortage to the financial challenges to the preferred partnerships that are aligning, we really set out with our program to try and help improve in those areas. And so we developed a team and a model of care that I'm going to share with you now on the next couple of slides here. Next slide, please. So our team is made up of a geriatrician as our medical director, and getting ready for growth, we added a few more sites this year with some CMs that we had in our second year of the 3 years. And so we have just hired a second board-certified geriatrician as well. So we now have 2 geriatricians on staff here at our hub. They are supported by a team of individuals, and long-term care team is very important. It takes an interdisciplinary approach to really provide the care. And so we have a pharmacist who has her geriatric certification that works full-time for our team. Our hub is staffed 24/7 by a certified nurse practitioner. We also have added a psychiatric nurse practitioner. We know that behaviors are definitely something that long-term care facilities need help on, and so that's why we brought that team member onto our team. We also have RN coordinators who assist our nurse practitioners and physicians, and they have all also gotten their geriatric certifications. We have a licensed social worker on our team that can support the facilities, as well as other administrative and support staff. Next slide, please. This slide really depicts then the 3 main pillars of our program and how we go about servicing the long-term care facilities that we partner with. And I know earlier I said that we were in 4 states. We currently have 35 long-term care facilities as of today that are actually live with our services. And due to some funds that we still had remaining with CMMI, we're going to be adding another 10 to that. So with the CMMI funds, we will have 45 long-term care facilities in those 4 states that we will be supporting by the middle of November of this year. So our 3 pillars, the first one is staff empowerment. And so back a few slides, I said when we were in our HRSA days, we really needed to be more proactive in the care that we were providing. And so this pillar really focuses in on trying to help empower the staff to be just that, more proactive in the care that we are providing to the residents in those facilities. So the number one thing is we provide them access to a geriatric team, which I went over in the last slide, really what that team consists of. They are have a very large lack of resources typically in the long-term care facilities, especially the ones that are in the rural areas. They don't have access to a lot of specialists or people who can help them provide care. A lot of times, especially on the night shift, you'll have a facility where there's maybe 50 residents they're caring for, and there's 1 nurse in the building and a couple of certified nurse assistants. And they're responsible to provide care to all of those residents. And you can imagine if there's an emergency with one of them or 2 of them, how that would stress out and take all of the time of those staff. So really being available and being another part of their team that they can rely on over phone and over camera is a big part of that staff empowerment. We also provide education sessions to our facilities every month so that they can dial in and see different education that we're providing, get CEUs for their licenses. We gear our education sessions around what are we seeing our customers send people back to the hospital with. So for example, we had a lot of customers that were having issues with wounds, and so we brought in a wound specialist and did education 1 month on wound care and provided that to them. We also provide committee support to them, so if they have a quality committee that they would like us to help support, medication management committee that they would like us to help support, we can do that. Advanced care planning is a very large focus of our team, and our social worker spends the bulk of her time on advanced care planning. It's very important to make sure that the long-term care residents that are in this country are planning for what they want in end of life. Studies will show that a lot of the people who go back to the hospital end up passing away at the hospital, and that's probably not what their wish was, but the right conversations didn't take place in time for them to make those wishes known. And so really trying to be proactive and have those conversations early on. And then we also work closely with the Interact program and can provide support and coaching as certified Interact champions as well. The second pillar focuses in a lot on that proactive care as well, but management of care and care transitions. So when a facility has a new admission to their location, we will do an admission review. We look at their risk for potentially going back to the hospital or being transferred to the ED. We do a medication reconciliation and medication review to make sure that their medications are correctly ordered and they're taking what they need to be, and that there are diagnoses associated with all of those medications. We're available to the long-term care facility staff for order clarifications. Maybe the diet order is not correct, or they need certain labs drawn in a couple of weeks, and we can help make sure that those orders are all in place. We then follow them through their stay at the long-term care facility, and when they go back to their home, we also do a discharge follow-up to make sure that they return home successfully. So again, they're not being readmitted to the hospital or back to the long-term care facility or going to the emergency room unnecessarily. Throughout all of this, we keep in close contact with the primary care physicians. We certainly cannot replace the primary care physicians. They do a great job considering the resources that they have. We just want to be a support to them like we are to the residents and to the long-term care facility staff. We also provide transfer review support, so if a facility does transfer a resident, we're available to help them take a look at that transfer and help them see how could we improve in the future to maybe avoid a transfer such as this happening again. Our third pillar then goes back really to the HRSA days, and that's providing easy access to care. So being available 24/7, 365 days out of the year for them to call and us to pull them up on video, and providing timely responses so that they can get what they need to provide the care to the residents, whether it's proactive care or a response to an urgent need that is going on at the time. Next slide, please. Essentially, those are the three main pillars that we provide to our customers and the team that we have in place. And I thought I would just share some statistics that we're seeing in the early days of working with the sites that we have been at. So I talked about the fact that we do medication reconciliation and medication reviews with our team. And this is a significant thing to monitor because studies can show that a third of the time when people are readmitted to the hospital or have some type of adverse event, it is associated with medication-related issues, especially in the elderly. And so we are essentially taking a third look at the medications on most of these residents. Most of the time when they get admitted to a hospital, they will have a medication review and reconciliation done. When they get discharged, they will have one done as well, but the resources at those times do not always have what they need in order to give it a 100% accurate look. And so we look into as much as we can pull up with their medications, and over 50% of the time we are finding something on that third look that is not right, that we're needing to write a recommendation to change or write an order to change to make sure the residents are getting the right care that they need. Next slide, please. One of the most important statistics to share today is, of course, the treatment in place percentage. So this graph shows as our program has grown, the treatment in place. So if you look back in December 2014, that's shortly after we got the CMMI award and when we were starting to hire the geriatric team. It wasn't until about November of 2015 when we had the full team in place. And so you can see that as we've added more specialists in the geriatric care area, we've been able to increase our treatment in place percentage. And so right now today, each month, we average about 85 to 90% of the time we are able to treat residents in place versus having to transfer them to an emergency room or back to the hospital, sometimes which is over a 100-mile one-way trip for the elderly in the parts that we serve. Next slide, please. This slide shows the unplanned transfer rates per 1,000 resident days. That's the way that we break that down and study that. So as you can see, as we've been integrating into the locations that we serve, we've been able to help them reduce their unplanned transfer rates, with July of this year being our most significant month to date of unplanned transfer rates. So this is just showing that over time, the more we get integrated into facilities, the lower we see the transfer rates going down by providing the support of those three pillars that we have. Next slide, please. And this is one that I always like to share that shows unplanned transfer rates associated with engagement. So we do have sites that, for whatever reason, they've maybe had multiple leadership changes with their site leaders that are not as engaged as other sites. And so this slide shows as engagement of the site goes up, as you can see, especially from February through June of 2016, unplanned transfer rates will decrease. And so the more engaged we can get a site with the pillars of our service, the lower unplanned transfer rates they have. And so this really is a large focus of ours entering the third and final year of our CMMI award that we just entered here at the beginning of September, because we know by the numbers that we have that if we can engage them more on the different services that we offer, we will see even more significant impacts happening. Next slide, please. These next two slides really just focus in on what type of impacts are we seeing with the long-term care facilities that we are servicing. So of course, an increased access to urgent care services. It's not abnormal for long-term care facilities to reach out to a primary care physician at 7 or 8 in the morning and not hear back from them for over a day or 2 days, because those physicians are just that busy with what's already going on at their clinic and at the hospitals that they are servicing. And so we're able to give them a more response and provide timely care to the residents and support to those nurses. Of course, I talked about reduced rehospitalizations, reduced unnecessary ER visits. We help the nurses to have a decrease in paperwork, phone calls, and faxing. Every time they're transferring someone in and out, the amount of paperwork that they have to do is very time-consuming. We have seen this impact nursing staff recruitment. Most of our locations significantly struggle for staff to take care of the residents that they have in their facilities. And we have had them use this as a recruitment tool. So trying to fill that night nurse position, that night nurse now, instead of being 1 against 50, knows that a phone call and camera away is eLong-term care to provide support to them. We have seen increased satisfaction and lower turnover rates as well. Also, resident and family satisfaction has increased. We were not sure at first how the residents and families would react to the technology, just knowing the generation that most of them are in, but they have openly embraced it and are very interactive over camera and really like working with our team and being treated in the place that they call home. Next slide, please. We have also seen a decrease in transportation costs when these sites are not having to transport people back and forth to the hospital and multiple miles for clinic visits. We're helping them to maintain census so they have residents in their facility and revenue coming in their doors. A lot of them deal with managed care, and we're able to help them maintain their managed care reimbursement. We're helping them to take care of higher acuity of patients so that they can compete with their competitors and make sure that they are one of the leading locations for elderly care services. We've seen lower pharmacy costs by finding things in the medication reconciliations. And of course, back to the preferred partnerships, are really helping these locations form those preferred partnerships and make sure that they are doing what they need to move on in the next years to come with those partners. Next slide, please. So really, we have taken the CMMI funds and we've developed a team and workflows that we have found statistically to be very valuable to the long-term care facilities and very impactful. And now we're ready to grow beyond that CMMI award and grow beyond those 45 locations that we are going to be servicing as a part of that CMMI award. We are actually approached very regularly by individuals interested in adopting e-long-term care for their facilities. We've had significant conversations with over 10 large organizations, actually in over 20 states. So we are, of course, developing a model for sustainability. However, philanthropic support would help us move more rapidly and would also help us to have a faster adoption by most rural facilities. Like I stated earlier, one of the significant things with the long-term care facilities is that they do have a very low margin business and cash on hand is not very accessible for them. So the biggest hurdle we a lot of times run into in conversations with people as we look at moving beyond CMMI and providing these services is affordability of the services. And most of the time we get caught up in the capital costs, buying the equipment to connect over video, making sure they have the proper connectivity, having a circuit that is ran to their facility can be very costly. And then of course having the IT infrastructure at their location that they need to support the equipment. So those are the first hurdles that a lot of times we run into when it comes to the scaling. Next slide, please. This slide is just a reminder that we always share with everyone that most of this service today is being funded by the Centers for Medicare and Medicaid Services. Next slide, please. And we are going to get into questions towards the end here, so next slide. And I believe, John, I hand it back over to you for a moment now.
Yes, indeed, and thank you so much, Josh, for that very important and in-depth report on this program that's moved forward very rapidly. Heidi, I know that you wanted to talk a little bit more specifically about opportunities for the philanthropic community in programs like this, so let's turn it back to you.
I want to be sure and leave time for questions, and both Josh and I would be available for follow-up as well. But as Josh mentioned, a big hurdle for these, especially the more independent, and I'm using air quotes here, the mom and pop long-term care facilities, which we see a lot of in rural, deep rural and in frontier areas, do not have capital sitting around waiting for this wonderful new innovation. And we saw the same thing when we were working with critical access hospitals to uptake the telemedicine that Helmsley is providing. So this is just a look at how you could get involved. You know, you're interested in this project, you think that your area of the country or state would be interested in this. This is kind of how we looked at it. We looked at the expenses that are holding entities back from, coming on to an amazing service like this. And we typically do our grants over 3 years. So this is just a sample. We help a lot in the first year because that's when you have your site set up with the equipment, you need the connectivity, you need the IT support, and that's going to be a little different for each site, and depending on what they have as for broadband in their area, et cetera. And then we also help with getting entities started with their service cost. We tend to design our grants so that we help a lot, very significantly in the first year, less in the second year, and in the third year we basically are kind of phasing off the grant. But still helping with a portion of those ongoing service fees, so that in this case, the long-term care facility would be able to kind of get ready for their budget to afford the ongoing expenses. Next slide, please. And so we have done this with 3 different products that we have funded critical access hospitals to utilize of Avera's eCARE. And we've done it a lot of different ways, and I can see funders doing this in a variety of ways in the future too. If it's a system or maybe a smaller rural health system, or maybe there's multiple long-term care sites owned by the same ownership group, you know, you could help a whole group come onto the services together. You could do funding individual sites. We've done it both ways. There's pros and cons to each way. Comprehensive funding, we kind of shy away from that. We really like to see that the entity is strongly interested and involved enough to put a little bit of their own money into the you know, being able to afford a new innovative project. So we do kind of require some in-kind from the entity. We've learned a lot about scaling, as has Avera. We can do some follow-up if anyone's interested. And you know, the amazing thing about these programs is we get such a large amount of data, and we're constantly learning, we're constantly researching. Avera's constantly looking at innovation. In our grants, we get external review, as does Avera, to see, you know, how are these working, how can these grants work better and these projects work better. We publish, rewrite, we have external people publish and write, and Avera's out there presenting as well. The other thing Avera does a really good job on, even if you're not going to come and utilize their services, we have people from all over the country and really internationally come to the eHelm in little old Sioux Falls, South Dakota, to see how we're doing this, because it truly is a one-of-a-kind, probably the largest system that's providing this kind of virtual care services. So I'm going to turn it back to Josh now, or I'm sorry, John, for questions.
Thanks so much, and thank you for this wonderful presentation. And we will turn to your questions now. And I'll start with you, Josh, with a question about payment. So you talked about the CMMI grant and other kind of special funding, I guess you would call it. But who is the payer for most of these services? Is it traditional Medicare? And are there difficulties getting the Centers for Medicare and Medicaid Services, or CMS, to approve e-services for payment?
Yeah, thanks for the question. Right now, today, what we are doing is being funded by the CMMI award, but as we look at sustainable payment methodology beyond the CMMI award, we have a few things that we're looking at. One is a business-to-business relationship. That would be where the long-term care facility would contract with us to provide the service, and then we would sign over rights of any applicable billing to that long-term care facility, that there might be billable occurrences that they could bill insurance or CMS for to get funding out of those programs. We did look at, there is some telehealth codes that you can bill to CMS and other insurance companies for some of the work that we do, but it's very, very minimal in terms of what is allowable and what is what we are able to bill for. So that's really not a sustainable method. We continue to have conversations with CMS, though, of how could we move this beyond the CMMI phase, seeing that it is significantly impacting the amount of money that they're spending on care for the people that we serve, and they're seeing reductions in that cost.
Heidi, a question to you. If you are a smaller local funder, and obviously you are a regional funder, and you've talked about the levels of grant that you find helpful, but you're not in a part of the country that has an established program like Avera's program, what advice would you have to those funders who are looking for something like this but don't know where to turn?
I would contact myself or really anyone at Avera. We're pretty well in the know of what's out there as far as kind of telemedicine. I would say the telehealth to long-term care is even a little newer and less dispersed across the country. But I would say between one of us, we would probably have a good awareness of what might be in your region or your kind of your neck of the woods.
I expect you're going to get some calls.
Great. That's fine.
So Josh, back to you. Is there a number of patients that's required for a critical mass to justify or maintain this investment? And I think that you could probably ask that question on two different levels. I mean, is there a certain number of patients per long-term care facility, a certain number of facilities that are needed, or can you do it with any size?
The easy answer is we could do it with any size, and then it's my job on this end to try and figure out how I budget the books based off of how many residents we have. We always tie our overall expenses for our program into a per resident number, so how much does it cost us to provide care per resident. All the facilities across the country are different in size significantly, so I can't tie it to number of facilities on the program. But we honestly can grow to whatever we're able to grow, whether we would just adjust our staffing. So as we bring on more and more residents, we would need to, of course, add additional geriatricians and additional staff to make sure that we're providing the right amount of care to them.
Okay. Back to you, Heidi. Is there a long-term vision on the part of the Helmsley Charitable Trust around this issue? Is it entirely based in your 7-state region? And how do you see this evolving over the next 5 to 10 years?
So, yeah, so the Rural Healthcare Program of Helmsley is focused only on the 7-state region. And then elderly issues actually are not part of our strategic plan. So while we are thrilled and love this program, it's not something that we're going to help fund getting it out and scaling it. We've already kind of helped with the infrastructure just through building the infrastructure of eCARE and their ability to kind of really work on innovation. So this isn't something that's kind of on our radar, although we love it. There are some other programs that we're watching that are in their innovation cycle that probably will be on our funding radar over the next 5 years. We are huge fans, though, of telemedicine because we've seen how it can work in these frontier regions. The other thing I wanted to, sorry, John, to follow up, the individual that asked about, who's doing this in our region. I mean, they can do these services from Sioux Falls, South Dakota, anywhere. So when we scaled up the e-emergency, e-ICU, and the e-pharmacy, we went, because our funding is in 7 areas, but they have gone beyond that now. So they're down in Kansas without us. They are out on the East Coast to 2 or 3 states without us. Initially, we kind of looked at scaling. We thought we would need regional hubs so that folks would feel like, oh, these are people from my region of the country. It's very expensive to build up this type of infrastructure. So what we've found is it's actually better and easier and more financially responsible to build up this existing infrastructure that we already have. So when we per se reach capacity, there isn't capacity. We just keep building the infrastructure, usually through just staffing.
Okay, great. I think what's going to be our final question before I return to both of you for your final comments, are you at this point trying to influence state policy, particularly regarding telehealth reimbursement, which is often the driver of long-term success? And I think that's particularly because, of course, the states have a very large role in the Medicaid funding side of long-term care, which is so important here. Are you involved in any advocacy efforts or policy efforts along this line?
Yes, we are. We keep a very close eye on what's happening at both the federal and the state level when it comes to reimbursement, regulations, the different laws that impact the healthcare industry and telehealth. And we are constantly advocating and lobbying to make sure that they understand the significance of telehealth, and by maybe providing more funding to telehealth, what that could mean in terms of dollars saved. But it's a change. It's a mindset change, and so it's going to be a long uphill battle, I believe, in a lot of those areas to get them to understand what we can do in terms of the programs.
And we don't do a lot formally, I would say, but we do tend to host decision makers, lawmakers, other health systems to this part of the country to see what can be done with telemedicine, and then we are always mentioning what the barriers are, and which is typically issues with broadband and then reimbursement. The other thing that we like to do is we fund some other entities that do research on these kinds of issues, and then do writing and kind of policymaker advising on issues affecting rural health care. And they obviously are big fans of telemedicine as well because of what we can do with it.
Well, thanks. At this point, I wanted to turn to both of you for your final comments. Josh, let's start with you.
Yeah, I just want to thank all of you for your time today and the opportunity to share what we have done so far with eLong-term care and what impacts we're able to have with our program. And so we're very excited around here at eCARE about the possibilities of growing this much above and beyond the 45 sites that we have partnered with through the Center for Medicare and Medicaid Innovation Award that we received. And I think one key thing that I just want to share that Heidi said and reemphasize is we really can go anywhere with this program. We are in the 4 states that we're in just because that's where our partners through the CMI award were in. But we have the availability and capacity to really grow beyond that and help serve wherever is needed in the rural communities. And I just encourage people, if they have questions, to certainly reach out to me. My contact information was on the presentation.
Thanks. Heidi?
Yeah. Any kind of telemedicine to rural areas, to go ahead and reach out to Josh or myself. It's exciting. It's something, you know, that I love. It's near and dear to the trust work, and we've seen how it changes lives. And I also want to just really give some accolades to Avera, the health system we've partnered with that created eCARE. The reason we partnered with them is their mission so highly reflects and works with what ours is. They are truly focused on rural entities, those rural providers. How can we keep people where they call home or close to home without sending them to the big cities? So we really have appreciated our partnership with them, and we'll continue, you know, to work with them. And also, you know, that multi-state thing, they are able, because they've built up this infrastructure, they have staff here to work on the things like licensing and credentialing of physicians in multiple states. So that's not much of a barrier. It is to single entities, but to you know, a facility like this, an organization like this, we have the support needed to deal with interstate issues. So thank you so much for having us today.
Well, thank you. I want to thank Josh Hofmeyer, the Senior Care Officer at Avera eCARE, and Heidi Schultz, the Program Officer for Rural Health Care at the Helmsley Charitable Trust, for their participation in today's program. We thank you for all you do to make life better for older adults. I also want to thank the Johnny Hartford Foundation for their continuing support of this program, and today's co-sponsors, the AARP Foundation, Grantmakers in Health, and the Helmsley Charitable Trust. We will be making this presentation available to anyone who wishes to view it later, including both the slides and the audio. Watch for a rebroadcast link, which will be on our website at www.giaging.org, or contact Grantmakers in Aging at info@giaging.org. I want to remind the funders on our call to be sure to register for the GIA annual conference coming up in Portland, Oregon on October 26th to 28th. As I mentioned, we are offering a half-a-day workshop on aging in rural America, and in partnership with Grantmakers in Health, also a session on policies, programs, and solutions to help older adults living in rural areas. Information is on the GIA website. Please join us for our next webinar on fostering dementia-friendly communities on Thursday, October 6th 2016 at 2 p.m. Eastern Time. And finally, I want to thank all of you for participating in today's webinar. Have a great day.